So we've invited Jeff McMahon, who is PA in our hepatology division, to come and give this talk about the simplified treatment of hepatitis C. We have started a hepatitis C consultation service here that has shares the same phone number with the HIV consultation service, and it does have a separate website too. So if at any point you feel the need to ask a question to one of the hepatology team, you are more than welcome to call that number, and we will facilitate that for you. And I will let you take it away, Jeff.
Okay, great. Thanks, Shannon. Good afternoon, everyone. Thanks for joining us. So as Shannon said, today I'd like to walk you through a simplified approach to managing patients with hepatitis C. So really, with the development of safe and highly effective antiviral therapies we've been using for the past few years, treating hepatitis C has become much less complex than it has in years past. And so a majority of the patients that we see in clinic, certainly who are mono-infected, can be treated with a more streamlined model that I'm going to review with you.
Did this to Dr. Brower, so it should work now.
Oh, very well. So I have no disclosures that are relevant to this discussion. So hepatitis C has gotten the attention of the World Health Organization, and they've eliminated their goal to eliminate viral hepatitis as a major world threat by 2030. They're hoping to reduce new infections by 90%, treat 80% of those who are eligible for treatment, and ultimately it's felt that this will result in a 65% reduction in mortality rates. However, as a challenge to this, we're seeing a rise in the annual incidence of new hepatitis C infections, and this is mainly because of the opioid crisis. And so hepatitis C is no longer just a condition for baby boomers. You see an equal distribution among young adults, those aged 18 to 39. And further, it's not just a condition that's confined to urban and suburban areas, because we're seeing a rise in rural settings as well. So what we're seeing is that hepatitis C is reaching new demographics, both in terms of age and geography. So what types of things can be done to achieve this goal? Certainly you can improve blood safety and infection control, extend harm reduction to those who are injecting drugs. But really, I think the biggest impact is going to be in expanding testing and treating these patients. And what that means is increasing the number of providers who are treating hepatitis C. So the state of Michigan has also developed their own plan. It's called the We Treat Hepatitis C Initiative. And as part of this plan, there's support and education for providers. But one of the biggest things that's developed is they've eliminated some of the barriers for patients to receive medication from an insurance standpoint. So that may improve the number of patients who can be treated as well. Now, much of what I'm going to show you today comes from this AASLD IDSA guidance document. This is a really good website, and I would encourage you to use this as a reference in your practice. It's very user-friendly. The recommendations are clearly stated, and it's a great source of context, whether your questions are about testing, managing, or treating patients. Now, within this guidance document, they've created what's called Simplified Hepatitis C Treatment. And this is really something that you can streamline therapy and do just the basic workup, what needs to be done, what testing needs to be done, how do you assess fibrosis. It really is for a majority of the patients that we're seeing, and we're going to walk through that. And it's within this guidance document that you can print these handouts. I put them on here because I thought they're a great reference. You can print these out, put them in your clinic, and they're easy to refer to as you're seeing patients. So let's start with hepatitis C testing. So as of now, who needs to be screened for hepatitis C? So historically, it was just recommended to screen those with risk factors for transmission. Those recommendations have broadened. In 2020, it was recommended to screen all baby boomers with a one-time check for hepatitis C. But as of March 2020, it's recommended that anyone over the age 18 should have a one-time check. Now, in addition to adults, it's recommended that anyone under the age of 18 be checked for hepatitis C if they have high-risk exposures. Any female presenting for prenatal testing should have a one-time check. Well, actually, with each individual pregnancy, they should be checked. There should be periodic testing for individuals who are engaged in high-risk activities, annual testing for individuals who inject drugs, men with HIV infection who have unprotected sex with men, men who have sex with men and are taking HIV pre-exposure prophylaxis should have annual testing. So as we go through this talk, I'm going to refer back to this flow chart. I thought it provides a good framework for how we move through the stepwise process of evaluating a patient and then safely getting them started on treatment. So we're going to start with just the basic hepatitis C test, the hepatitis C antibody test, and the quantitative HCV RNA. So the standard hepatitis C screening test is the hepatitis C antibody. If that's positive, that indicates prior exposure to the virus. Not necessarily current infection, but just prior exposure at some point in the past. So this can occur either in the context of an acute or chronic infection. In an acute infection, the antibody will take about 8 to 12 weeks to become positive. Now, to be honest, we rarely see a patient who has acute hepatitis C. Most of these patients are asymptomatic and they move on to chronic infection. But it can also be positive in about 20 to 30 percent of patients who've been exposed to hepatitis C can clear virus spontaneously. So those patients will still have an antibody, but a false positive result is rare. And so all positive results should be worked up, which brings us to step 2, and that's the HCV RNA. So a positive test here indicates the presence of viremia, and that patient has active hepatitis C infection. If the antibody is positive and the HCV RNA is negative, that would indicate that they're one of the lucky 20 to 30% of patients who cleared virus within 6 months of exposure. Now, just as a note, if you treat somebody and they've cleared virus and you want to know later on if they still have hepatitis C or they still have cleared virus, you're going to want to check the HCV RNA rather than the antibody because that will always be positive. Here's a flow chart just to reinforce the point. So you check an antibody, moving to the left, it's non-reactive. That patient does not have hepatitis C, but with one exception, they make a note that if you have an immunocompromised patient, you'd want to check the HCV RNA because that patient may not have produced the antibody.
So in our patient group, so in HIV infected patients, if the suspicion is high, then we should always be checking the HCV RNA.
Yeah, I think I have seen that before, or a fellow patient in the past where the RNA was positive, but the antibody was negative because they're immunocompromised. Yep. So starting back at the top, moving down, if the antibody is reactive, you check the HCV RNA, that's detected, that patient has hepatitis C and they should be treated. Let's say, moving to the right, the hepatitis C, or excuse me, the HCV RNA is not detected, antibodies positive, that patient does not have current infection. If you have a patient where you suspect acute infection or has an elevated AST, ALT, but their HCV RNA is negative, you may want to check it again in 3 to 6 months, probably closer to 6 months, because in the acute phase, sometimes the viral level will go below the limit of detection. And so if they have, hepatitis, they have elevated AST, ALT, but the HCV RNA is negative, you may just want to check it again in 3 to 6 months to see if it's still negative. If they still have elevated liver enzymes, then they should be referred to have those worked up. So that covers the antibody test and the HCV RNA. I'm going to talk for a minute about genotype. So you may wonder, now that we have these pan-genotypic regimens, these regimens that work for all genotypes, do we still need to check it? And I hope to make this as simple as possible. So if a patient does not have cirrhosis, you do not need to check the genotype. The genotype's only recommended for those patients with cirrhosis that you plan to treat with a sofosbuvir/valpattizivir regimen, okay? So the reason is because if that patient is genotype 3, it's recommended they have resistance testing. They may have what's called a resistant associated substitution, or a RAS. And if that substitution is present, that patient may need an alternative regimen with the addition of ribavirin or a triple combination therapy. So it's just for cirrhotics that you're going to treat with the soft val regimen. If you're going to treat a cirrhotic or any patient with the glucapavir preventative regimen, then they don't need genotype testing. If you have a patient who's received a prior DAA in the past and has failed therapy, those patients also need to have genotype testing because that may dictate which regimen they get with their second round of treatment. So again, genotyping is only needed in a cirrhotic that you're going to treat with a sofosbuvir valpatisvir regimen.
And the only reason really to go to the sofosbuvir regimen would be drug interactions. Are there other?
Drug interactions is one.
I think it has to be like,
It mainly has to do with a cirrhotic who is borderline or decompensated. So the GLP-1, that regimen is contraindicated in decompensated cirrhosis. So sofosbuvir, you would need to use, let's say you had a patient who looks maybe borderline decompensated, lower albumin, bilirubin just above the upper limit of normal. And so they're kind of borderline, not obvious ascites or encephalopathy. That's a patient you probably want to treat with the soft-vel regimen rather than the glucapavir preventative regimen.
So those would be two reasons.
Right, right.
if you have somebody who, because I know the glucapavir preventative regimen is the one that's most commonly used. If they say they're going to have trouble taking it with a meal for whatever reason with their scheduling, how much does that matter? Because I know the sponsor of valpatisvir does not have to be taken with food.
Yeah, that hasn't really come up too much in our practice, the associated meals. So I know, that regimen is 3 pills or 3 larger pills. Often our patients will take it in the evening, but that issue of being able to, just swallow that regimen has only come up just once or twice. Liver fibrosis assessment. So this is an important step, and this must be done in all patients. You want to have an idea of how much fibrosis may be present, certainly identify if that patient has cirrhosis. Now, thankfully, there are a number of non-invasive tools available where fibrosis can be assessed. Most of these patients don't need a biopsy. So I'll go through those. Transient elastography, also called FibroScan. This has been our go-to since around 2013. The issue with FibroScan is it may have limited availability or limited access to it. There are serum biomarker tests. These are fibrosis panels. So in a sample of blood, they use different markers to assess fibrosis. Some of the commercial available biomarker fibrosis panels include FibroSure, FibroSpect. There's a newer one, FDA approved, I think in August, called the Enhanced Liver Fibrosis or ELF panel. So those are available at different labs. But also FIT4 and APRI are scoring systems that are easy to use because they basically just require a liver panel and platelets. And so these can be done at any time in the clinic. And they have very good negative predictive values to rule out cirrhosis. So we'll take a look at those 2 scoring systems in just a minute. Now, what about ultrasound? Do you need to check an ultrasound in all patients? The issue with the ultrasound is it's insensitive for cirrhosis. So you can have a patient who's cirrhotic, but the ultrasound is reported as unremarkable. So it's not a great test to assess for fibrosis. Now, if you have an ultrasound or imaging that reports liver nodularity, now you can say with a high degree of confidence at that point that that patient likely has cirrhosis. If you identify a patient with cirrhosis, you do need to check the ultrasound before treatment just to assess for HCC. And I make a comment there also that if you have a patient with platelets less than 150, that's typically also considered a cirrhotic as well. And just these guideline handouts I mentioned earlier, just to show you, this is all within the handout, these cirrhosis assessment tools. So again, this is just a good reference to use. Here's the FIB4 calculator. You can Google FIB4 and there's a number of calculators that come up. This is just one, but it just takes age, AST, platelet count, and ALT, and it comes out with a score. If your value is less than 1.45, you can say with a good degree of certainty that patient does not have cirrhosis. If your value is greater than 3.25, then that patient would be considered cirrhotic. That has a 90% specificity for advanced fibrosis. If you have a value that falls in the middle or is indeterminate, you may have to go back and use another tool to assess their fibrosis. There's also the APRI score. This just takes AST over the upper limit, which is usually around 35, over the platelet count. And if you have a score of less than 1, this will correctly identify patients without cirrhosis in 93% of cases. Now, what happens if you do identify a cirrhotic? The important step is making sure that that patient has compensated disease and they don't have current or past decompensation. So any history of ascites, encephalopathy, prior variceal bleeding, that patient would be considered decompensated. And the reason why this is important is because the protease inhibitor regimens, including glucophage, preventative, are contraindicated in anyone with decompensated cirrhosis. This was a lesson learned when the first protease inhibitors were approved back around 2013 or so. Patients who had maybe borderline cirrhosis or decompensated disease were started on treatment, and we saw a number of them decline further. And so the protease inhibitor regimens are now contraindicated in those patients. If you identify a patient with cirrhosis, remember you're going to need to screen for HCC, which means an ultrasound and AFP. And then also they're going to need some assessment to screen for varices, so they'll need an EGD. Now, what's helpful in determining whether that patient is compensated or decompensated? You can use the Child-Pugh score. This takes into account 3 laboratory values and then whether or not they've had a history of ascites or encephalopathy. This is another just scoring model. You can again Google this, and there's different apps to figure this out as well. But it puts in these 5 criteria, and if you have a score between 5 and 6, that patient is compensated. They're a Child's A. If they're 7 or above, that patient is decompensated. Okay, so just looking at this, if you have a patient, for instance, with no encephalopathy, no ascites, normal bilirubin, but if their albumin is less than 2.8, that would technically mean that they're decompensated. And so you would want to further work that patient up. If you have an ultrasound that shows just a little bit of ascites, I would consider that patient decompensated as well, and I would avoid a protease inhibitor regimen. So that is our liver fibrosis assessment. Now, what labs are needed? What basic labs are needed before you get going? So if you have a non-cirrhotic within 6 months prior to treatment, it's just recommended to check a CBC, INR, hepatic function panel, and eGFR. If they're cirrhotic, they want that closer to 3 months. And really, that's probably mostly just to look at the INR, albumin, bilirubin, make sure those are appropriate values. You can have a quantitative HCV RNA anytime before treatment. You don't need to check a viral level just before they get started. Almost all of these patients on therapy are going to become negative, so you're not going to need to track their viral level reduction as they get going. Other tests you're going to want to check is HIV antigen antibody test, and check for hepatitis B with a surface antigen as well. Now, if you have somebody with recent high-risk exposure to those, you're going to want to check those just before they get started on treatment. Because if they're HIV positive, certainly that's going to need to be addressed and treated. And there are a number of drug-drug interactions with that regimen, with those regimens and hepatitis C treatment. Now, if they're surface antigen positive, meaning they have hepatitis B, the issue there becomes these patients can flare or they can reactivate their virus if they start on a hepatitis C treatment. That was also another lesson learned when the DAAs became FDA approved. This is data showing that hepatitis B reactivation occurred in 24% of patients treated in this data set. So if they're surface antigen positive, these patients are going to need to start on hepatitis B treatment before starting their treatment on C to get that under control. And I'm just going to mention this because this comes up. If you come across a patient who's isolated core total antibody positive, that just indicates prior exposure in the past, but not necessarily active infection. But if you come across this, these patients really don't need prophylaxis. The risk of hepatitis B reactivation in these patients is rare. If you find a patient who's just isolated core antibody positive, again, meaning they're surface antigen negative, you can just monitor them with an ALT every 4 weeks. And if that becomes, if you have an unexpected rise in the ALT, you can check an HBV DNA. What about hepatitis C in pregnancy? Well, we mentioned before that all pregnant women should be checked with each individual pregnancy for hepatitis C. If you have a female of reproductive age, talk with them about getting treated before pregnancy to reduce it's a small risk of vertical transmission, but it is there, and they can prevent this risk from occurring. If you start them on treatment, they're going to need some sort of contraceptive or protection from getting pregnant. Because the thing is we're really not treating patients while they're pregnant with hepatitis C treatment. It's really not recommended. There's just not enough safety data out there to recommend it. There are a few small studies and it appears safe, but these are just, there's very limited studies. And so really treating a patient for hepatitis C should be deferred until after delivery. So who are patients who really should probably be referred to a specialist, a gastroenterologist, hepatologist, or just receive some specialist attention? So anyone with a history of decompensated cirrhosis, they may need to be looked at for possibly transplant. There's a few additional things to pay attention to in those patients. Prior hepatitis C treatment, this is mainly referring to patients who have received the DAA regimens in the past. It becomes a little bit more complex if they have not responded to their initial treatment, whether it's sofosbuvir, valpattizivir, or glecaprevir, preventative, one of those regimens. So that also requires specialist care. End-stage renal disease is kind of an interesting one that they keep on there because the regimens that we use, the pan-genotypic ones, with the exception of the triple regimen, but sofosbuvir, valpattizivir, and glecaprevir, preventative are both okay to use in patients with end-stage renal disease, including those patients on dialysis. I think it's just kept on there because these patients are generally more complex. They may have lower albumins, they may have a little bit of ascites that may not necessarily be portal hypertensive ascites, but I think they kept it on there just because of the complexity of these patients. We mentioned HIV and hepatitis B, surface antigen positive patients, current pregnancy, known liver cancer, and any prior transplant patient should be treated at the transplant center. So we've done a majority of our workup thus far. We're on the home stretch. And the last thing that needs to be checked is drug-drug interactions. What I would recommend is that you make yourself familiar with a reference, a website that will help you review drug interactions. There's a number of them out there, so it becomes challenging just to memorize them all. But this becomes very handy. This is a very popular one. The University of Liverpool has a website, hep-druginteractions.org, very easy to use. Just to mention, some of the most common drug-drug interactions are statins. You can use rosuvastatin at 10 milligrams. So some of our patients will take them off their current statin and switch them to rosuvastatin at the direction of their PCP, or just hold their statin for the 8 to 12 weeks they're on treatment. PPIs, that's a common drug interaction, and anticonvulsants as well. Not all of them, but some of them are. So you've done your whole workup. And so here are the recommended regimens. These are what's available now. But really, what we're using are the pan-genotypic regimens. So sofosbuvir, valpattizivir, and glecaprevir, preventative. These are really the main two regimens we're using for the initial treatment of patients. They're highly effective. The sofosbuvir, valpattizivir is given for 12 weeks. You can see cure rates, or we use the term sustained virologic response, or SVR, but it's basically a cure, greater than 97% across all genotypes with and without cirrhosis. And here's the GLEED-PIB regimen, glecaprevir, preventative. This is for 8 weeks. Some of the arms are a little bit lower at 90%, but that's just because the numbers are lower in those genotypes. Those are more rare genotypes. But really, this regimen is just equally as effective. You can see here in cirrhotics, 99, 97%, and that's given for 8 weeks. How often do we need to monitor patients on treatment? Well, this is a study, the SMART-C study, and this looked at whether patients could just be monitored by phone, which is the simplified monitoring arm. They just received a phone call at weeks 4 and week 8, or do they need to be seen in clinic? And so the standard monitoring arm included clinic visit at week 4 and week 8. Now, what's important to note was this study did exclude patients with anticipated poor adherence, active drug use in the past 6 months, or a positive urine drug screen. So it kind of pre-selected some patients who may have better adherence. So let's see how they did. And you can see in the intention to treat arm, really there wasn't much of a difference, okay, 3.2%. And both arms were relatively adherent. what the authors stated was, using clinical judgment to determine, which patients you would be comfortable with just a phone call. Okay, again, this study did exclude those with active drug use, those who are anticipated to, have noncompliance in the past. Those patients you still probably want to see in clinic at week 4 and week 8, because compliance is really important with these regimens. We only have a handful of them available. So if you're not compliant with the first treatment and it doesn't work, it becomes difficult because there is a salvage option, but after that, it becomes much more tricky. And so you ideally want to just get rid of this the first time. So compliance does become very important. And that's something that's really emphasized to our patients when we see them the first time in clinic. I do want to point out the side effects. This is fairly typical of what you're going to see. Less than 1 out of 5 people are going to have a side effect, and it's mild. Fatigue, headache, nausea, sometimes diarrhea. But these are, again, mild. Adverse events are not a reason for discontinuation amongst the patients that we see. We really don't need to prescribe much in terms of an antiemetic. A headache can be taken care of with a Tylenol, but these patients don't need prescription pain medications or other prescription medications for their side effects. Now, what about treating those with active drug use? Is that a problem? Well, this is data showing on the left, you can see there is good adherence in this population. This is from what's called the Simplified trial. And how effective is it in patients with active drug use? Well, you can see still a high SVR rate or cure rate, over 94% for patients actively using. There is a push now to treat these patients, because if you treat somebody who's actively using, that means they will not affect someone else. So it's felt, there's certainly clinical discretion involved, but it's felt to be acceptable to treat these patients. What about after treatment? You've treated your patient and they're cured. Do they need follow-up? Really, just the cirrhotic patients do. If you identify, that's why the fibrosis assessment pre-treatment is very important. These patients are going to need to be screened for liver cancer throughout the rest of their life, and that becomes a big undertaking. The more patients you treat, we're trying to figure out the best practice for that as well, and how to do ultrasounds every 6 months and AFPs for these patients, because 6 months comes very quickly. It feels like you just did the last ultrasound, but these patients do need to be followed, because we do see it. We see patients who were cured a few years prior, 4 or 5 years prior, and they show up now with a mass that's consistent with HCC. And so ideally by screening, you're going to catch that when it's still small. What about reinfection risk? You can be reinfected. This treatment does not make you immune to being exposed to hepatitis C again. So those with ongoing exposures should be checked every 6 to 12 months. But if they're not at risk for ongoing exposure, they can just have an annual ALT and promote liver health with a healthy diet and minimizing or eliminating alcohol. This again just illustrates the point of hepatocellular carcinoma. It was recognized in the interferon treatment era that those with advanced fibrosis or cirrhosis, while they did reduce their risk of liver cancer, it was not eliminated. So it still exists, and we still need to screen these patients. So I hope I've made it appear simple.
Just go back to that slide of.
Yeah.
So this is only for cirrhotics, right?
Correct. Yeah. So these are patients. So this came out of 2012, but I imagine they had biopsies in these patients to determine whether they were F3, F4. So these are patients with advanced fibrosis, and those who didn't achieve a sustained virologic response, you can see the risk of HCC after 10 years being 21%. Those who had a sustained virologic response, it was reduced, but it's still at 5%.
And that's why in the guidance it says that patients with advanced fibrosis, even if they've had a sustained virologic response, should continue to be monitored for hepatocellular carcinoma, right?
That's correct, right?
So that's F3 and F4 only, or is it?
It's F3 and F4.
Yeah,
I know, and as of now, I mean, unless additional data comes out about the F3 patients, it really, most people would screen an F3, F4,
okay.
and definitely,
And below that,
no, and below that.
if they've sustained virologic response, you don't need to screen them for hepatocellular carcinoma.
Right. I've heard some clinicians call somebody with an F3, well, that's a cirrhotic.
Yeah,
They feel that they're cirrhotic. And so I think most practitioners would screen an F3 and F4.
okay.
It's a hard undertaking. Our department's trying to figure out best practice for that because we're just accumulating more and more patients. The cure rates are so high that need to be screened.
And there's no other reason to really follow them except to do the ultrasounds,
Correct.
right?
Yeah, just an ultrasound and AFP. They don't need to be seen. Well, I mean, if they're a cirrhotic patient, you probably do need to see them.
Oh,
Right? Yeah, if they are cirrhotic, because they're going to need, screening for varices, whether that's, what their previous EGD showed. Do they need one at 1 year, 2 or 3 years? So if they're cirrhotic, you probably want to see them, at least once a year, just to, see how they're doing, follow their course. But it's a frustrating scenario when you treat somebody and a few years go by and they somehow slip through the cracks without screening and they show up with an HCC. You feel like you would have just, if we would have just done that every 6 months, you would have identified it when it's small. So in summary, again, I hope this appears somewhat simple. Assessment can be limited to fibrosis staging. Most patients, you can assess their fibrosis with some of these non-invasive tests, checking for hepatitis B and HIV and drug-drug interactions. Genotype testing you really don't need it for most patients. You don't need it if they're a non-cirrhotic. It's really just for cirrhotic patients you plan to treat with the soft val regimen. On-treatment monitoring is limited to those just with adherence concerns. Otherwise, you can do, just a check-in at week 4 and week 8 with a phone call. You do want to check labs every 4 weeks in a cirrhotic patient. And then again, post-SVR follow-up limited to HCC surveillance and those with high-risk exposures. So again, use this website as a reference. It's a great source. I still use it. A lot of the clinicians in our practice use this for guidance. It provides great context. And as Shannon mentioned, we have this hepatitis C consultation program. This is free provider-to-provider advice. We're here to help out and support you in any way in managing patients and helping with any sort of question you have. So thanks very much.
Do we have questions? I think Monica can unmute everybody.
Other than that one scenario where you want to use soft val that you mentioned with like borderline patients, is there any other considerations you take between those two medications or any pearls in that?
It's drug-drug interactions, but what you find is that the sulfosbuvir valproatovir regimen does have an interaction with PPIs. Okay, some patients can't come off those, and so you're going to have to use the glucapavir preventative regimen. In terms of the anticonvulsants, they're somewhat similar. There's not many differences there. So now the clinical trial for cirrhotic patients in the glucapavir preventative regimen, they actually allowed albumins as exclusionary criteria was an albumin of 2.8 or less and a bilirubin of 2.0 and higher. I tend to prefer a cirrhotic having an albumin of 3.5 and above. I think those of us who use protease inhibitors when they first come out learned a few lessons with some certain cirrhotics that we wanted to be aggressive and treat, and some of them didn't do as well. You saw an escalation of the bilirubin. Some started to maybe tip in the wrong direction and develop ascites. So if in a cirrhotic patient, you really want to make sure they're well compensated, in my opinion. But both regimens work well, and so it's often dictated by insurance.
Yeah, I was.
Yeah, so we're going to talk about that.
Right. So, and that's something we have to keep in mind. again, as long as both the drugs are equal,
Yeah,
that the preferred drug for Medicaid is GP,
Yes.
Yeah.
right? So, if you don't want to go through the hassle of, prior
Right, if there's-
authorizations and all, that is the preferred drug. And as long as there's no contraindication to it,
yeah, it's an 8-week regimen.
8
Okay,
weeks.
so very quick. The side effect profiles are so similar. Most patients come back and they say, I really didn't even notice I had side effects.
Mhm.
So I would view both regimens as equal in most ways, with the exception of, in cirrhotic patients, if you feel that, they're well compensated. It's okay to give. They give it to a lot of cirrhotics who had compensated disease and did well. But you just, with the protease that's there, you want to make sure that they're well compensated.
And then in the HIV infected, we have to be a little bit more careful about drug interactions with the HIV.
Exactly. Yeah, that really becomes the careful area with HIV co-infected patients is the drug-drug interactions. Yeah.
And I think what's at least beneficial is we're putting a lot more people on integrase inhibitor-based regimens, and those tend to be more friendlier. They have fewer
Yeah.
interactions than
Less
like if they're on a protease inhibitor rather.
Right.
So just so everyone on the line understands that GP is the preferred regimen for Medicaid plans, that does not mean that they do not consider other regimens if there are drug interactions or things like that. They will approve them, but the process is more difficult. So if you write for GP, you just write it and they go down to the pharmacy and they get it filled. There's not a prior authorization. There's not this process that used to be in place. They've removed the sobriety test. They have removed restrictions on mid-level providers or advanced practice providers around prescribing. So you no longer have to have the approval of a hepatologist or an ID doctor or some other specialist saying, oh yes, nurse practitioner or PA, you know what you're doing, go ahead and prescribe this. And so that it opens the accessibility and the ability of folks to treat that normally in past would not have been able to treat hepatitis C. And so we really are looking to develop new treaters for hepatitis C because it's important that we get these folks treated so that we can get this epidemic of hepatitis C under control, particularly in this younger group of folks who are becoming newly infected. When I was on the call with the We Treat Hep C and the Hepatitis Collaborative the other day, I was shocked to learn that they thought there were up to 300 children in our state who need hepatitis C treatment. That's a lot of kids.
Right.
Where I was sort of like, what? And so that kind of took me aback a little bit that there were that many pediatric patients. There is now a pediatric formulation. I learned on that call. You probably already knew that, but I didn't know that, that they can give to children. And it is in a pellet form, which I kind of want to see what that is. What is the pellet that they give to the pediatric population? So anyway, those were just some comments I had around making sure that people do understand that this is accessible, even if you are not a hepatologist and you're not an ID doctor and you really want to treat, you can do that, and we will guide you. Are there any other questions on there, Monica, in the chat or anything?
Nope, anyone can go ahead and unmute themselves or send a chat and I can read the question if they want.
Yeah, I have a question. My name's Craig Weeks. I'm a family doctor up in Saginaw, and I do HIV and viral hepatitis treatment as well. As far as surveillance for hepatocellular carcinoma after you treat an F3, F4, I don't typically order an AFP, though I would get a every 6-month ultrasound. I guess as far as AFP goes, what would you do with an AFP should I be ordering it?
Yeah, so it's a good point because there is, some of the guidelines, the guidance document will actually say that you don't necessarily need to do an AFP. It's not a great test. You could just do an ultrasound every 6 months. AFP has been around for a long time, so a lot of, I think, practitioners who have been around since the earlier development of screening practices just continue to do an AFP, but it is acceptable to just do an ultrasound every 6 months per some of the guidance documents. So An AFP is helpful. It can be elevated just in the setting of hepatitis C by itself. That inflammation can cause it to be elevated. So sometimes actually when we treat somebody, we start to see an AFP decline. But, if you have an elevated AFP, what I would do is maybe get a CT scan. If it's markedly elevated, just to make sure that the ultrasound is not missing something. An AFP over 400 is diagnostic of HCC. So, but it's rare to see AFPs, above probably 100 without there being something there. Or if you treat them and you start, I have seen a few AFPs where it's been above 100 and we treated them and it shot right down. So again, it can be a misleading test. You're not necessarily at fault just by checking an ultrasound every 6 months.
Okay, thanks.
That was a good question.
Nothing in the chat so far.
Okay.
Okay. Yeah. So we can give you back a few minutes of your time today. We do appreciate you coming on to virtual rounds. Again, avail yourself of the service. And when Jeff's office figures out how to monitor all these people, we'll revisit that. I'm a workflow person, so I like to know these things.
So this is what we've done. We've developed a smart phrase that we're supposed to explain to our patients and let them know, if you want screening, here's the number to call, and they'll call one of our nurse navigators and they'll put the orders in. But we're kind of putting some of the responsibility on them to say, this is the process. You've been told that, you need, you're still at risk of liver cancer, you need an ultrasound, and we're using AFP every 6 months. Here's the number to call, and you'll get into this program to be screened. So that's where we're at right now.
Okay.
But to see everybody every 6 months is really cumbersome. It comes up really fast.
Yeah.
I mean, you order the ultrasound and then they have it 6 weeks later, 8 weeks later, that's 2 months. I mean, it's just.
Yeah, so it's hard to keep track of those.
In terms of other cancers for screening, this is every 6 months is a lot, but, we do see it from time to time. And, until there's other data out there, you could, with liver disease, you anticipate regression of disease over time. The hepatitis B data has shown that even cirrhotics will, regress and their histology doesn't show cirrhosis after 5 years of antiviral therapy. So it's anticipated that would happen with hepatitis C. The data on using something like FibroScan years down the road, they do show improvement, but there's been some criticism of that because when they had their initial FibroScan, they had hepatitis C, they had inflammation. So it's not like an apples to apples comparison. And so those recommendations aren't out yet. Perhaps in years to come, we'll be able to better identify which patients still need screening. There's some biomarker tests that are still in studies to look for some things to identify which patients will still need screening. So hopefully in years to come, we'll be able to take
To weed out.
weed out some of those patients.
Yeah.
So.
Okay. Thank you.
Oh, thank you.